evening's module, and today we are going to understand about neurological disorders in geriatric population. So I hope we were clear with all the three modules what we had um, seen before and heard, learned before. And now we are going to do every condition wise specific geriatric population. Which particular conditions are most commonly seen? How do you tackle? And what do you do in such conditions? Everyone clear? Everyone is with me? Any difficulties? So today we are going to understand the neurological conditions which are most common. First is stroke and its rehabilitation. Second is Parkinson's disease. Third is dementia and Alzheimer's. And then is a discussion. So the most important thing what you need to understand that the neurological disorders have to be extremely been aware about the things. If you are not aware about the symptoms, it is very difficult for you to understand whether it's a neurological problem or some other problem. So I'll just take an example of Parkinson's. Tremors, slowing of the movement, or slowing of gait is also the most common things what you see with age. But if you correlate the other symptoms with the main features of mask face, too much kyphosis, balance issues, coordination issues, then it is very important for us to immediately send the patient to the neurologist, and so that they can start with the Parkinson's medication. So awareness is very important. If you are aware at a very early stage, it is easy to tackle and very easy to manage. So now first thing what we are going to understand is stroke and its rehabilitation. So can you anyone tell me what is stroke and why it is most commonly seen in old age population? Anyone? What is stroke?
Stroke is like a symptom of um, something that happens in the brain when there is a clot or some kind of occlusion.
Obstruction of blood flow to the brain.
Exactly. Obstruction of the when there is an obstruction of the blood flow to the brain, to the areas where the blood is not flowing, that area goes for degeneration and necrosis, and the functions of that area is lost. So stroke is most commonly seen in old age population. Why? Because with the age, your all the arteries become very resistant. They become very tough. So the blood flow can be restricted. Second, there are a lot of clot formations inside the arteries which can also reduce the blood flow, which is going to the higher centers. Third, if you have extreme higher blood pressure and too much of stress, anxiety, or loss of medicines, they're not taking medicines, can lead to hemorrhage and can also lead to stroke. Okay, so stroke is the third leading cause of life lost worldwide. It's most commonly able disability. Acute ischemic stroke accounts for 85% of stroke, and other 15% accounts to hemorrhage. The increase of the stroke burden is mostly seen with the aging populations, and age is one of the non-modifiable factors of the stroke. Okay, and there is always an increase in the incidence of stroke with the increase in the age. The age people have higher prevalence of stroke because of certain problems like atrial fibrillation, atrial hypertension, diabetes, heart failure, coronary artery disease, and also some kinds of higher cholesterol and occlusion problems. Okay, so these are the major comorbidities in the aged population that can lead to stroke. And the most common disability what you see in the old age population is majorly because of stroke. Everyone clear? Any difficulty?
Clear, ma'am.
Okay. So first thing, as a physiotherapist or the occupational therapist, or even as a normal person, it should be very aware. It should be very aware about us to how detect stroke. So the very common synonym what we come into the picture is fast, FAST. So it is a key to stroke survival. If you see these symptoms in any of the patients who are coming to your clinic, or if you see in any of your family members, make sure that you take the patient immediately into the emergency department. So F stands for face. any face drop on one side while smiling. A stands for arm, where the particular side of the arm is not able to move. S means speech, if there is any slurring of speech or the person is not able to speak well. T means time, means immediately you have to take the patient to the emergency department, because in stroke there is something called as golden period or golden time. If you make the patient reach in a very less time with the help of anticoagulation therapies, the patient can be easily survived faster and can have full recovery. If and when the time passes, the blood flow is restricted and blood flow is not moving, then the chances of survival or the chances of full recovery goes down. Everyone clear? Yes, no?
Yes, ma'am, clear.
Okay. So can anyone tell me two types of stroke and how what is the pathophysiology of that before we go ahead?
Ischemic and hemorrhagic stroke.
Ischemic and hemorrhagic stroke, ma'am.
Okay, what is the pathophysiology of that?
Hemorrhagic is when
Ischemic stroke.
something some blood vessel get ruptured and there's a blood everywhere, and ischemic is when it's blocked inside.
Perfect, perfect. Anyone else?
In hemorrhagic, there is necrosis in one part due to the accumulation of blood, and in
Hmm.
ischemic, the blood flow is not proper.
Perfect.
Ischemic is due to deprive of oxygen to the blood, like to the brain.
Exactly. So if the blood is not reaching to the brain in the ischemic one, as we know, every part of our body requires oxygen to function. So if the particular area is not getting enough oxygen, that can lead to loss of the function and can lead to stroke. So there are different etiological factors or multifactorial parts of the stroke. First, it could be genetic and family history. Second, could be vascular, specifically dyslipidemia or endothelial dysfunction or vascular problems. Then, it could be because of the cardiac origin, like a person who has low atrial fibrillation, hypertension, or any coronary artery disease. It could be metabolic. Metabolic means diabetes mellitus, thyroid, obesity, or any inflammatory problems, or vasculitis. Vasculitis basically means any inflammation of the vessels or the blood vessels. So, if there is any inflammation of the blood vessels, the vessels are not working properly, that can also lead to stroke. So, stroke is multifactorial. It is very important for us to understand what is the origin of the stroke, where the stroke is coming from, and treat the underlying root problem. So, I had seen one of my patients. It was his history that the patient suddenly had stroke. Okay, and they were not able to find out what was the reason. So they missed something called as the rhythm problem. So patients who have rhythm problem, okay, in heart, when there is a rhythm problem, the amount of the blood which is pumping out of the heart will not be good. If the blood is not pumped, obviously the brain will not get enough blood, enough oxygen. That can also lead to stroke. So it is very important for us to understand what is the first, precursor where the stroke is coming from. You have to fix the heart, then you have to fix the brain. If you're not fixing the root cause, the repeated events of stroke can definitely happen. Everyone clear? Yes, no?
Yes, ma'am.
Yes. So, stroke is multifactorial disease with numerous potential causes. Specifically in older adults, it is more complex because it is age-related factors, it is frailty, it is comorbidities, and a lot of medicines can also lead to stroke. Aging also promotes vascular changes, at which I had already mentioned that when the age happens, the entire artery becomes very thick, becomes less elastic, becomes very stiff. That can also lead to less blood flow or also can lead to hemorrhage. So as you can see in this particular chart on the right hand side, the prevalence of the stroke keeps increasing with the age. Okay, so the patients who are at a higher age, who has hypertension or diabetes for more than 15-20 years, can can be at the risk of developing stroke. So it is very important for you to educate such patients whoever coming to your clinic.
Ma'am, what is comorbidities?
Comorbidities basically means how many conditions you have. Conditions basically like diabetes, hypertension, thyroid, metabolic disorders, obesity, cancer, those are the extra comorbidities. Understood?
Yeah, ma'am. Thank you.
Yeah. So there are certain risk factors of stroke. First, it is modifiable and non-modifiable. Always remember, we can definitely modify the modifiable risk factors. If you start rectifying the modifiable risk factors from an early age, the chances of developing stroke at the old age will be very less. Okay, and there are non-modifiable factors which you really cannot focus on, but if you start changing the habits and lifestyle, it can definitely work. So the modifiable risk factors are lifestyle problems, then lack of physical activity, heavy addictions of alcohol, smokings, not having good sleep. So these are modifiable. So if you know that a person has a family history of stroke, and if the person starts doing all these changes at the age of 40, 50, so the chances of developing stroke at the age of 60, 70 will be considerably reduced. Which are the non-modifiable factors like age, sex, family history, genetic components? Okay, so these are the non-modifiable factors which you cannot really change, but you can definitely work on the modifiable factors. Okay, and if you start working on your modifiable factors, which are specifically the lifestyle problems, the chances of not having stroke increases by 50 to 60% according to the research. Clear?
Yes, ma'am.
So the lifestyle modification or the things what I'm
Yeah,
telling is a primary preventional strategies. So every chronic diseases. So as you can see, stroke is also one of the chronic diseases. So every chronic disease have three type of preventional strategies. Okay, what I'm telling is from the PSM book, which is a Park book. You can definitely refer. So as a physiotherapist, it should be very important for us to start screening the patients at the early age. Early age basically means 30, 40, 50. Nowadays, I've seen patients having stroke at the age of 35 also. Specifically, it is because of stress and lifestyle problems. So, if you start screening such patients and you start making the changes at a lower level, is called as primary prevention. Now, what is secondary prevention? Secondary prevention basically patients who have developed stroke, and now you have to treat them. You have to make sure that the second attack of stroke doesn't happen. So, in secondary stroke prevention, the major thing what you have to see is comprehensive risk assessment, properly finding the solution, assessing the patient in detail, having a medical management, which is very important. Second is the lifestyle management, and third is a regular follow up and reassess. Everyone clear?
Yes, ma'am.
Yeah. So how will you screen such patients? Obviously, there are different screening strategies. How you screen is basically you take a history of if they have family history, the age, the sex, the other comorbidities like diabetes, hypertension, also the physical activity history. So you take all this history to screen the patient whether they are at the higher risk of stroke or not. If they're at the high risk of stroke, you have to immediately start with lifestyle modification so that the chances of developing stroke is reduced. So our work starts from the primary prevention level and it goes to the tertiary prevention level. Okay. So physiotherapists and occupational therapists have the job at every preventional strategy. In the primary prevention, your main goal will be to make the patient exercise, to make the patient fit so that the stroke doesn't happen. In secondary prevention, your aim will be stroke rehabilitation so that the disability doesn't happen. And imagine if the person goes into disability, in tertiary prevention, you have to focus on disability care. Clear?
Yes.
Yes. So
Ma'am,
now, yes.
one doubt in the previous slide. Ma'am, one of the factor was mentioned like excessive use of anticoagulants. So anticoagulants is something which will prevent the clot from getting formed, right?
Yeah.
So that how can that be one of the cause, ma'am? Like what is the connection between that hemorrhagic stroke and anticoagulants?
So hemorrhagic means, bursting of any artery. Okay. If the person is on too much of anticoagulants or warfarin for a very long time, as you know, it's a blood thinner, right? So they will keep having a lot of loose blood. If there is too much of loose blood and there is a sudden increase in the pressure, the entire vessel can break and that can lead to more hemorrhagic strokes. So in such patients, you have to be extremely careful about the PT-INR ratio. You have to be extremely careful so that they don't have falls. If they have falls, the vessels can break and that can also lead to hemorrhagic stroke. Clear? Or any internal bleeding for that matter.
Okay, ma'am. Thank you.
No problem. So now we'll be coming to the management. We have discussed about the stroke, the prevalence, the factors. How do you assess? How do you work at prevention levels, secondary and tertiary levels? Now we are going to come to the stroke management. Okay. So very important. Stroke is a very big term. In stroke also there are classifications. Could be a first of all it could be paresis or paralysis. Paresis means weakness, paralysis means entire loss of muscle strength. It could be a unilateral, basically on one side. It could be bilateral, or sometimes it can also be only in one arm, or it can be in one hand and one leg also. So depends on the area which is affected, which vessel is affected, then the stroke can be altered. Just a minute. So, first thing what we need to remember is which vessel is affected. So, as we know, in our brain, we have three types of vessel. One is the major vessel is anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. So, every cerebral artery has its own territory where they supply the blood. Imagine if that's an MCA is affected. MCA is basically its middle cerebral artery. If that is affected, the major damage happens to the hand and leg. In ACA, which is an anterior cerebral artery, majorly the damage is in the leg. If it's a PCA artery, PCA basically it supplies to the occipital part, the eye, and the balance part, the cerebellum part. So in such patients, the balance, coordination, and the vision is a problem. Okay, so depends on which artery is affected, which area is affected. The affected area of the stroke will be different, and the patient's presence will be different. So the major important thing what you need to understand is stroke management starts from the hospital. It starts from the acute care. So many patients who are into the acute care, your first line will be to manage the patient medically. So what is the medical management specifically? They will start with anticoagulants, they'll start with the blood thinners, they'll start with streptokinase, urokinase, then they'll start with to see whether where the stroke is coming from. If it's because of hypertension, they'll start with the BP medications. So there are different, first the patient has to be medically managed. Second, you have to see whether the patient is conscious or not. If the patient is unconscious and patient is not breathing, you have to put the patient on mechanical ventilator support or see what is the breath control. So according to the breath control, the settings can be changed. Third, then you have to see whether how the urine output is. Is the blood pressure being maintained or not maintained? So you have to put the catheter, you have to maintain the blood pressure. When the person is vitally stable, then only you have to start with physical therapy. So always remember in acute phase of a stroke, the first line comes for the medically management. Second comes the physiotherapist, where you have to keep um, the body in movement. You have to keep the chest clear. You have to make sure that no tightnesses or no stiffnesses or no contractures have been formed. Because in the acute stage of stroke, there will always be flaccidity. There will be no tone. Once the recovery happens, then only they will start developing spasticity. Clear? Yes, no?
Yeah, ma'am.
Yes. So, always remember stroke is a upper motor neuron lesion, so there will always be spasticity. Okay. And the acute line of management in the hospital will be to maintain passive movements, to do stretchings, to keep the chest clear. If the patient is understanding or following commands, you can ask them to spit it out. If the patient is not, then you have to do suctioning. Then you have to make sure that the nutrition is being optimized, and there should be a sodium restriction always if there is a high blood pressure. The sleep has to be totally in a proper way. And once the patient is aware and the patient is shifted to inpatient, treatment rooms, then you can start with slow hand movements, leg movements, exercise. Depends if it is assisted, if it is passive, or it is active assisted. It depends on the patient's phase of the condition. If the patient is extremely passive, you have to do all the passive movements. If the patient is little doing the movements around grade 1, a flicker of movement, you can start with active assisted exercises. And if it is just a TIA, TIA is basically a transient ischemic attack, in which the patient recovers the entire strength, entire body movements within 24 hours of the stroke. In such patients, you can start with all the active movements. In such patients, you can always start with more weight bearing exercises, promote more of sitting, promote more standing with the help of the hospital staff and the family members. Clear? And then once you do the assessment, you will understand which is a problem. And then you can go ahead with the different neurological techniques like Bobath, NDT, Roots approach. You can do a mix of different approaches to in order to start treating such patients. Then there are different other types of treatment options like cognitive support, psychosocial support, and cardiac rehabilitation. So stroke is also significantly exacerbate on the cognitive decline, because as you know, the patients sometimes lose their consciousness or they lose their understanding. They are very confused. So in such patients, it is very important to start with mental stimulation exercises. Second is psychological support, because as the patient has undergone stroke, they are into a shock. They will not understand what they do, what are they doing. Some patients can slip into depression. Some patients, they will start sensing that now they are become dependent on somebody. So in such thing, you have to always have a family support, good psychological care, and also caregiver support, and the exercises have to be maintained. If you feel that stroke is coming because of any cardiac origin, so cardiac rehabilitation has also been proven to reduce the chances of stroke in future. So these are the different line of managements what you have to consider before starting the treatment. If you feel that there is a sensory problem, please start with sensory awareness techniques. If you feel that one side is affected, increase the weight shifts, increase the awareness of that leg. Attention has to be given. If you feel the patient is not conscious, is not hearing you, you can give some verbal or tactile cues. You can give some colorful charts to them so that they start seeing, they can start hearing. You can always give them, or make sure that the TV is on so that they can see and they start having a mental stimulation. Environmental modifications have to be done for such patients, because treating or long term treatment is the most important thing. Okay. And safety programs. Again, whatever elderly safety programs what we have learned yesterday has to be applied here as well. In physiotherapy techniques, the major important is you have to start using the hemiparetic side, more start having bilateral movements. Also, if you feel there is lot of flaccidity which is seen, you can use different splint techniques like AFO, KF4, or hand splints can be used so that the tightnesses and stiffness are not formed. And also, once the patient comes to your clinic, you can always start with functional based activity or bilateral activity. Everyone clear till now? Any difficulty? Yes, no?
Clear, ma'am.
Okay. So stroke is clear. Now we are going to go to the second topic, which is Parkinson's. Okay, can anyone tell me what is Parkinson's, and have you seen such patients? Stroke is very common.
Yes.
Okay, what is Parkinson's?
Parkinson is we can use trap as uh, like tremors, rigidity, akinesia, and postural instability.
Here. Okay, that's a definition of Parkinson's.
I would
Decreased dopamine in the brain.
Decreased.
Dopamine, ma'am.
Yes, okay. And
It's a fascinating gait. That's what I know about it.
okay, no problem. So
There is
Parkinson's.
some degeneration in the basal ganglia.
Yes, correct. So it's a neurodegenerative disorder in the basal ganglia area where the amount of the dopamine formation reduces drastically, and dopamine is required to, it's a neurotransmitter which is required to have balance and coordination. If there is no dopamine, the balance coordination will be affected, and the coordination between the two sides of the brain and two sides of the body will be affected, which can cause rigidity and also balance issues. Everyone clear? Yes, no?
Yes.
Okay. So always remember Parkinson disease, okay, is a very broad term. Okay, it's an umbrella term. So in that there are different types of subtypes of Parkinson's. Okay. So there will be many conditions which look like Parkinson's, but it is not Parkinson's. Okay. So one of the examples which I'm currently seeing as patient is progressive supranuclear palsy, which is called as PSP. The symptoms are same as Parkinson's, but the line of management, medical management will be a little different. Okay. So always remember Parkinson's disease or Parkinsonism is an umbrella in that there are different types of conditions which depicts Parkinson's. Okay. So for us, the symptoms is what we usually treat, but for a neurologist, it is very important to understand which is a problem and how to medically manage. Parkinson's is the most second common neurodegenerative disease after Alzheimer's disease. Parkinson's disease is a common neurodegenerative disease, is specifically seen in old age adults. Because as you know, degeneration with the old age, only the degeneration will come. But sometimes patients who have a strong link of family history or genetics can also have Parkinson's disease. So the most cardinal symptoms what you see in Parkinson's is limb tremor, shuffling gait, slowness, stiffness, postural instability, and also can be accompanied with different autonomic nervous system disorders, depressions, dementia, and psychosis. Okay, not compulsory that all the symptoms will be present, but yes, there are few cardinal signs if it is present, and there are different tests in order to understand Parkinson's. If it is confirmed, then first of all, they have to be medically managed. Then they have to start with physical therapy, which is the most important uh, treatment option in Parkinson's disease. So, physical therapy and occupational therapy always go hand in hand after the medical treatment. So, what is the diagnostic criteria of Parkinson's disease? So, tremors, specifically distal tremors, 3 to 6 hertz and higher frequency. Postural tremors can also occur. Muscle rigidity, velocity independent resistance to passive movement. Rigidity. So, what kind of rigidity you see in Parkinson's?
Will rigidity.
And lead pipe.
Yes, so goggle is what? So suppose you take an example of when you're assessing the rigidity, you take an example of bending the elbow. Okay, so when the person is bending the elbow and you see there is a phase of rigidity, then release, rigidity and release. It's called as cogwheel. And lead pipe is basically constantly in one range, you have the constant rigidity. Okay, it specifically feels more like spasticity only, but spasticity is velocity dependent, but muscle rigidity is velocity independent. Bradykinesia means slowing of movement and poverty of movement. Postural instability, basically, if they are not maintaining posture, there is too much of kyphosis, forward head, masked face is called as postural instability. Shuffling gait is very commonly seen. Shuffling gait could be anteriorly or it could be posteriorly. Okay. So these are the main different diagnostic criteria of Parkinson's disease. But there is one final criteria. This final criteria is usually done by the neurologist. So it's a sustained and a robust response to a dopaminergic challenge. Equivalent levodopa. Levodopa is a type of a dopamine medicine, which is given to the patients. And if they see a betterment of the symptoms, if they see that the symptoms are getting better and the patient is not having the symptoms, that confirms that the patient has Parkinson's disease. Clear?
Yes, yeah, ma'am.
Yes.
Yeah. So now what is the exclusion criteria, which I was telling about? Parkinsonism includes resting tremors and mild asymmetry, but usually they have essential tremors, tardive dyskinesia, and Parkinson's plus syndrome. So these are different conditions which mimics Parkinson's but actually are not Parkinson's. Okay. So there's something called as Parkinson's plus syndrome, like dementia with Lewy body, multiple system atrophy, progressive supranuclear palsy, which I was talking about, cortical basal degeneration. So there are different conditions which are there, but all the symptoms will be very similar to Parkinson's. So make sure that you don't get confused. And also the line of management will be very different in every different types of Parkinson's. So now we'll be coming to understand what are the different stages of Parkinson's progression. So stage 1 is mild tremors, postural change, and often on one side. Second is any noticeable movement issues on both the sides. Third is balance problems increases with the daily task and may need assistance. Stage 4, which is an advanced stage, is a severe mobility issues, tremors, and stiffness. Stage 5, which is a severe, means total loss of mobility and requires a constant care. So it depends on the stage, your line of management, your treatment will obviously differ. If the patient is coming at a very early stage, you can definitely start exercising vigorously in such patients, and you can always maintain the stage so that it doesn't progress. If the patient is coming to the advanced stage or severe stage, there is not much to do for you, but you can always maintain the musculoskeletal systems, you can maintain the limbs and muscles so that much problems does not occur earlier. Clear? Any difficulties?
Clear.
Okay. So now we'll be coming to the treatment approaches of Parkinson's disease. The first thing is a medical management where the levodopa or the syndopa is the most important thing what you have to see. Sorry, there was some network issue. So in treatment, first thing is medical management. One is levodopa and syndopa. So this is an additional dopamine which you have been, incorporating inside the body to make sure that the body gets enough dopamine. The neurotransmitter is working well. Your brain is working in a proper system, balance, and coordination, and the motor symptoms of the Parkinson's disease gets better. Then it could be carbidopa, which is the most widely used levodopa, and it's well tolerated by patients. So in many conditions, the dopamine has to be taken, or the levodopa has to be taken twice a day, thrice a day, depends on the condition and severity. And the next option is deep brain stimulation. This is usually done in very advanced cases like advanced or severe Parkinson's, where there are few points in the brain where the electrical stimulation is done so that the basal ganglia, which is degenerated, starts getting activated and starts secreting dopamine. Usually this doesn't work. There is very less research which is based on this, but definitely with the medicines and exercises there are seen great differences with the balance issues and the gait issues. So this is a picture which I've taken from one of the one of the studies with a systematic review where there is a strength recommendation, a higher recommendation of exercises in Parkinson's disease, and which have been shown a great effect on the motor symptoms. First is aerobic exercises like cycling, treadmill have shown better improvement. Second is resistance training like weight training. It could be with the help of dumbbells, barbells, or it could be because of body weight exercises. Balance training, where it can be with the sitting balance, standing balance, with eyes closed, eyes open. Flexibility exercises to maintain the muscle strength and also maintain the length of the muscle, because with rigidity the muscle length reduces. External cluing, basically if the patient has a lot of vision problems, you can use the help of the different stickers, different lights in order to make sure that they do the exercise, and community based exercise. So nowadays, there are many Parkinson's support groups where you create a group where there are 5 to 6 Parkinson's patients coming together and they are doing exercises together, and they are sharing the stories together. With that help also the psychological support is better, and also the patients exercises with each other. They see each other's improvement and get motivated. Next is gait training. Gait training is a most important thing which is important as Parkinson's patients because balance and coordination is a problem. And for gait we need both. Okay, so in gait you have to always see which part of the gait is affected. Is the lifting affected, or the stride length is affected, or the speed is affected? With the help of different techniques like putting sticker and ask the patient to walk, or do hurdle walks, or do side hurdle walks, do backward or side walks, also train the strength of the muscles, the gait training can be improved. Also after these exercises you can always start with functional task or the task oriented activities, where you can give them multitasking activities like you hold the ball, walk, you touch the ball, keep the ball, take the bottle. So these are the different task oriented activities which can be done. This is specifically done by the occupational therapist, because occupational therapists have to assess the environment of the patient and see whether what the patient is doing, and make sure to make the patient ready according to their occupation. Behavior change program. Many patients who have Parkinson's have a lot of mood instability like depression, anxiety. In such patients, they can be medically managed. Also, the psychologist support can be done. And also integrated care. Integrated care means when all the doctors and all the people are working together for the rehabilitation of patient. Telerehabilitation. Telerehabilitation is not really well accepted in Parkinson's because in such patients you don't know what can happen over online calls. You should always have a caregiver and the family member if you want to do telerehabilitation. Clear everyone with Parkinson's?
Yes.
Okay. So now we are going to go to the third topic, which is dementia. I hope everyone's clear with stroke and Parkinson's.
Uh, Ma'am, I'm a
Yes.
bit confused in medical management,
Okay.
like levodopa and carbidopa
They both
thing.
are same, just the name is different, and they work in the same format.
Okay, thank you.
Yeah,
Ma'am,
no
I have
problem.
a doubt. Now you're
Yes.
talking about Parkinson's plus. Now, can you please elaborate on that, ma'am, again?
Yes. So Parkinson's plus means anything which is added. Okay. So there are different conditions which just looks like Parkinson's but will have extra symptoms. But their origin, their pathophysiology is absolutely different from Parkinson's disease. So never confuse between two problems. Okay. But the line of management will be the same. So never just take an example. If one person has Parkinson's, one person has progressive supranuclear palsy. In
Mhm.
progressive supranuclear palsy, the added symptoms are neck stiffness, vision problems, and blackouts. But in Parkinson's patients, they will not have all these symptoms. Okay, so the
Oh,
addition symptoms is also what we have to consider. That is the only thing.
okay. Okay. Thank you,
Yeah,
ma'am.
no problem. Now, the third topic what we are going to come is dementia. Very common and mostly in every older individuals, you will see this. Okay, even in our grandparents, you will see this. Dementia is basically loss of cognitive functioning, thinking, remembering, and reasoning till an extent so that it interferes into patients' daily activities and life. Some patients do not have control over dementia, which can also change the personality of the patient. Dementia affects the millions of people and it's most commonly seen in patients above 85 years of age of aging. So, what are the signs and symptoms of dementia? Experiencing memory loss, poor judgment, confusion, difficulty in speaking, understanding, expressing thoughts, reading, and writing, wandering, getting lost in the family neighborhood, trouble handling money, responsibility, and paying bills, repeating questions, using unusual words which are not familiar, taking longer to complete a normal task, losing interest in normal activities, hallucinating or having delusions and paranoia, acting impulsively, not caring about others' feeling, and losing balance and having problems with movement. So, dementia not only means forgetfulness, but it has a lot of problems which can be related to the activity of daily living and the movements also. Okay, so if you see a patient, coming to you and they usually forget things, you have to find the symptoms. You have to ask their family members and caregivers about the symptoms, and then you have to reason out, does the patient has dementia or not. So there are different types of dementias. Okay. One is a dependent, one is independent. So some patients who are dependent, so sometimes the dementia is very out of control. Okay. So in such patients, the patients will be dependent. Some conditions where the forgetfulness is not much so that the patient can handle themselves is called as independent dementia. Okay. So there are different types of dementia. Dementia is an umbrella term. One of the most common what we see is Alzheimer's disease, Huntington's disease, Lewy body dementia, vascular dementia, traumatic brain injuries, or normal pressure hydrocephalus. So any conditions which affects the higher mental functions for reasoning out or coordination issues can be leading to dementia. Few dementia is only concerned with the thinking ability, reasoning ability, but there are few dementia which can also be physical. Clear?
Ma'am,
Yes.
ma'am, what is the correlation between dementia and Alzheimer's disease?
So dementia is an umbrella term. In dementia, there is one type which is Alzheimer's. Okay. We'll be going ahead when we learn Alzheimer's so that you can correlate it better.
Okay, ma'am, thank you.
No problem. So, as you can see in this picture, why dementia happens basically. Okay. So, as I told, dementia is an umbrella term. In that, we have different types. So, one is Alzheimer's. In Alzheimer's, basically, what happens is in our brain, as we know, we have white matter and gray matter. Okay. So, there are abnormal depositions. Abnormal means normally there is no deposition. But suppose in these white and gray matters, if imagine the sand or the crystals gets deposited, obviously it will hamper the function of the brain, and that is why the person's reasoning, thinking, forgetfulness will happen. Okay, that happens in Alzheimer's, where there is a deposit of abnormal amyloid proteins which makes the lot of tangles and sees that the brain is not functioning properly. Second is frontotemporal dementia. In this, the frontotemporal, as you know, the frontal and the temporal lobe will have lot of deposition, and the major function of frontal and temporal lobe is thinking, reasoning, doing the activities, and temporal lobe is hearing. So these of the functions will be affected. Next is Lewy body. Lewy body basically, Lewy body is a type of a protein, abnormal protein, which gets start developing in your body and starts depositing. It's called as Lewy body dementia. And what is vascular dementia? Imagine the person has any blood clots in the certain cerebral arteries, and that particular area is not getting blood, and that particular area is having loss of function, and that can also lead to dementia. Clear?
Ma'am, can you elaborate on Lewy body dementia, please?
Okay, so Lewy body means anything which is like an object. So when these are the abnormal objects which are usually not present in our body, with the age, with the stresses, with the family history or the genetic components, these body starts forming in your body, and these body starts depositing into the white and the gray matter if of our brain. Once they start developing, they send bad chemical signals or the wrong chemical signals to our brain, and because of this the entire brain function is affected, and because of which the physical function is also affected. Clear?
Yes, ma'am. Thank you.
Yeah. So in dementia, as a physiotherapist or the occupational therapist, we don't have a much role, but there are few researchers which have proven that if you do a lot of task-oriented exercises, multifunctional exercises, cross brain exercises, which have shown to improve the mental stimulation of the brain and make sure that the symptoms are being controlled better. For the occupational therapist, it is very important to manage the dementia symptoms. You have to always educate the patient to always keep a small diary with themselves about their name, address, details, wherever they are going. Use simpler words, not use complex words. Okay. Have always a cue make sure that they are doing all the activities in a proper form in the day, so that they are not forgetting anything. So this entire task, entire routine is usually set by the occupational therapist. As a physical therapist, we should always focus on strength training and more of cross brain exercises. Clear? Any difficulties?
Yes.
Okay. Next, as we were going ahead to Alzheimer's, I'll be discussing about that. What is the difference between Alzheimer's and dementia? So, dementia is an umbrella term, as I already mentioned, like Parkinson's. In Parkinson's, there are different types. So, Alzheimer's is one of the type of dementia. It's a disorder of brain, most common form of dementia, and around 75% of dementia cases have Alzheimer's. Alzheimer's disease is a progressive disease that remains undiagnosed in the early stage. It is very difficult to notice the symptoms of Alzheimer's. In the Alzheimer's disease, there are abnormal proteins like A, beta, and tau proteins which get deposited inside the gray and the white matters and the neurons of the brain. And these brains and neurons don't function properly, and because of that, the patient has dementia symptoms. So as you can see in this nice picture, as you can see the white and the gray matter, how properly it is spread out. But with mild Alzheimer's, there is a shortening of the grooves and the white and the gray matters. The amount of the neurons keep reducing with the Alzheimer's disease. And with the severe Alzheimer, there is absolute shrinkage of all the gray and white matter. Imagine if the gray and white matter is going, your function of the brain is going for toss. Okay, there are very large ventricles, and because of that it can lead to mental problems and also physical problems. So people who are into severe Alzheimer's will be extremely dependent on the family members. There will be loss of movement, there will be loss of speech. The patient will not tell, will not speak, will not interact, and also will have complete forgetfulness. Clear with Alzheimer's introduction, everyone?
Yes.
Okay. So, what are the symptoms of Alzheimer's? First is loss of energy, confusion with time and place, conversation problems, memory loss, trouble with the simple tasks which they were able to do before, and change of moods. So, people who have bipolar moods will have chances of having Alzheimer's. So, all these symptoms are most commonly seen with old age. But for Alzheimer's, that's why it is very difficult for us to notice the symptoms at early stage to tell whether the person has Alzheimer's or not Alzheimer's. Okay, so there are different scales which are available, which are the cognitive scales which you can use in. There are also Alzheimer's scales which are available in the market where you can use these scales to tell whether the patient has Alzheimer's or not. So there are few options and there are tips of care what as a physical therapist or the occupational therapist we have to uh, you know, give to the patient, give to the family member or the caregiver. First is establish a routine, which I've already mentioned. The occupational therapist's main role is to understand the routine, set the routine so that the patient follows accordingly. Second is create a safe space. Obviously, the patient will forget where they want to go, where they want to move, where is their room. So that make sure that they have handrails, there is non-slippery floors, there is no thresholds. Encourage independence. You have to ask the patient to do the task on their own and have to be less independent. Effective communication. Whatever the language the patient knows, always use similar language and single words to communicate with them. Stay patient. Many patients and the family members get very irritated because the patient is not following commands. It is difficult for them because that relay of the center to the higher brain is not happening. So you have to calmly respond and you have to easily make them understand the things. Utilize the memory aids. You can always use notes, you can use calendars, you can use alarms, you can use sticky notes at every part of the house to make sure that the dementia patient or the Alzheimer's patient read those visual cues and do the particular activity. Engage in activities. As a physical therapist, we have to make sure that you give them mental exercises, physical exercises, so that the brain keeps working and the condition is maintained and taking care of themselves. Okay, so these are the few tips what you have to teach and do in dementia and Alzheimer's patient. There is no much neuro rehabilitation available, but with these tips and cares, you can always maintain the condition so that it doesn't progress. Everyone clear? Any difficulties? So we have understood about stroke, Parkinson's, dementia, Alzheimer's. These are the most four common neurodegenerative age-related neurological problem which we encounter in our daily to daily basis.
Ma'am, in Huntington's disease, is the like therapy is the same, or do we have some therapy for Huntington's disease? Because one of our patient was a Huntington's patient, and like they shake a
Hmm.
lot. So
Okay.
like, what
So
are
in so Huntington's disease is again, it's one of the genetic conditions where there is lot of tremors. Okay, so in such conditions, always remember that you have to focus more on um stability exercises and weight bearing exercises. Okay, make sure that you focus on these more. Once you do a lot of weight bearing and close kinematic chain exercises, the amount of the tremors will reduce drastically. Okay.
yes, ma'am. Thank you.